All right, let's get right into this explainer. We're mapping out the absolute highest yield USMLE Step 2 CK toxidromes, psychiatric emergencies, and advanced psychopharmacology matrices. We've broken this clinical architecture down into 4 distinct, highly targeted modules: autonomic toxidromes and withdrawal, advanced psychopharmacology, neuromuscular emergencies, and finally, high-yield pharmacological traps. Starting right off with Module 1, autonomic toxidromes and the withdrawal timeline. Okay, the absolute crucial point here is mastering this horizontal timeline. You're going to start with mild symptoms early on. Think tremors, anxiety, some diaphoresis around that 6 to 24-hour mark. But watch out, because this can rapidly escalate. Between 12 and 48 hours, you're looking at withdrawal seizures and alcoholic hallucinosis. And the real danger zone? 48 to 96 hours. That's life-threatening delirium tremens, marked by severe autonomic instability, fever, and total disorientation. Now, for standard alcohol withdrawal, diazepam or chlordiazepoxide is your go-to. But, and this is a critical board rule you cannot miss, you must pivot to lorazepam, oxazepam, or temazepam if the patient has any underlying hepatic impairment. Now, look at the sharp contrast here. With sedative hypnotic intoxication, you'll see profound CNS depression, but check out the pupils. They remain completely normal. Compare that directly to abrupt withdrawal, which triggers a massive autonomic storm, life-threatening instability, severe rebound anxiety, and seizures. It's like a physiological pendulum swinging to the extreme opposite. And this builds perfectly into our differentiator matrix. Pinpoint pupils, profound bradycardia, and dangerous respiratory depression. That screams opioid intoxication and demands an immediate naloxone push. But if they're withdrawing from opioids, the entire picture flips. Suddenly you're dealing with dilated pupils, rhinorrhea, piloerection, and severe diarrhea, where you'd reach for clonidine or methadone. On the completely other end of the spectrum, stimulant intoxication, like cocaine, presents with wildly dilated pupils, tachycardia, severe hypertension, and acute psychosis. And remember, stimulant toxicity carries an absolute unbreakable board rule. Avoid beta blockers at all costs, due to the risk of unopposed alpha stimulation. Let's actually test your active recall right now. Picture this: an agitated patient rolls in with an unknown drug ingestion. You note pinpoint pupils, bradycardia, and a terrifyingly low respiratory rate of just 6 breaths per minute. What is the precise diagnostic parameter here, and what is your immediate antidote? Let's break down the clinical logic choice by choice. The exact combination of meiosis, those pinpoint pupils, bradycardia, and a respiratory rate dropping to 6 breaths per minute instantly locks in your diagnosis as opioid intoxication. Now, you might be thinking, well, sedative hypnotics cause respiratory depression too, right? True, but in that case, the pupils would be perfectly normal. The meiosis is your smoking gun here. This presentation dictates immediate IV naloxone administration to reverse that respiratory collapse before the patient codes. And why do we definitively rule out beta blocker administration? Let's say this was actually a stimulant overdose masquerading as agitation, and you gave a beta blocker. You would block the beta-2-mediated vasodilation, leaving the alpha-1 responsors completely unopposed. That triggers massive vasoconstriction and a potentially fatal hypertensive crisis. You just can't risk it. Okay, moving right along to Module 2, Advanced Psychopharmacology Profiles. Let's map out these critical antidepressant toxicities, because they love to test these. SSRIs and SNRIs, they frequently cause sexual side effects. Bupropion is a great alternative for that, but it has a very specific, dangerous trap. It lowers the seizure threshold. So it is absolutely contraindicated in patients with eating disorders or a history of seizures. TCAs are a huge one. They can cause lethal arrhythmias marked by QRS widening on an EKG. The second you see that QRS widening, that is your cue to push sodium bicarbonate. And finally, don't forget MAOIs, which carry a severe, life-threatening risk of a tyramine-induced hypertensive crisis if your patient eats things like aged cheese or cured meats. Now, when we track mood stabilizers, strict monitoring is absolutely non-negotiable. With lithium, you have to constantly watch for nephrogenic diabetes insipidus, chronic kidney disease, hypothyroidism, and, if the patient is pregnant, the teratogenic risk of Epstein's anomaly. Shift over to valproate, and your radar needs to immediately lock onto hepatotoxicity and neural tube defects. And for lamotrigine, you have to titrate that dose incredibly slowly. Why? To avoid the severe, skin-sloughing terror that is Stevens-Johnson syndrome. And here is the classic antipsychotic divide. First-generation antipsychotics carry a massive risk of extrapyramidal symptoms, or EPS. Second-generation drugs, they lean heavily toward causing metabolic syndrome. But I really want you to focus on clozapine, right down there at the bottom. It is strictly reserved for treatment-resistant schizophrenia, and for very good reason. It mandates rigorous, nonstop tracking of the absolute neutrophil count, or ANC, because of the severe risk of agranulocytosis. That's on top of other dangers like myocarditis and severe constipation. Time for another high-stakes scenario. A patient being managed for treatment-resistant schizophrenia suddenly presents with a precipitous drop in their white blood cell count. What is your immediate pharmacological intervention? The clinical protocol here leaves absolutely zero room for debate. A precipitous drop in white blood cells in a patient on clozapine is a massive red flag. It signals the onset of life-threatening agranulocytosis. If you try to simply lower the dose or wait and see if the counts recover, you are risking complete bone marrow failure and a fatal opportunistic infection. The only correct intervention, literally the only path forward, is an immediate, full stop of the drug and rigorous, continuous ANC tracking. You have to halt the offending agent instantly to prevent mortality. Let's slide into Module 3, Neuromuscular Emergency Segregation, NMS versus Serotonin Syndrome. Okay, let's dissect NMS, or Neuroleptic Malignant Syndrome. This is a bizarre, idiosyncratic, and highly lethal reaction typically triggered by dopamine antagonists, like antipsychotics. How do you spot it? It is defined by pathognomic lead pipe muscle rigidity. The muscles are basically locked solid. You'll also see profoundly elevated creatine kinase levels, severe autonomic instability, and extreme hyperthermia. Your next best step, stop the antipsychotic immediately, initiate aggressive cooling, and administer your antidotes, dantrolene or bromocriptine. Now, contrast that entirely with serotonin syndrome. This is driven by overlapping serotonergic agents. The key difference? It's characterized not by rigidity, but by profound neuromuscular irritability. You're going to see hyperreflexia, tremors, and its own pathognomonic sign, inducible or spontaneous clonus. You'll still see autonomic hyperactivity and hyperthermia, but the neuromuscular exam is totally different. The fix? Stop all serotonergic agents and, for severe presentations, give cyproheptadine. So, this right here is your ultimate differentiator matrix. You absolutely have to be able to instantly contrast these two hyperthermic emergencies based on their unique reflexes. Burn this into your brain. NMS equals dopamine antagonists and stiff lead pipe rigidity. Serotonin syndrome equals serotonergic agents and hyperreflexia with clonus. Let's see how fast you can apply that matrix. A patient on multiple psych meds comes in burning up with a temperature of 104 degrees Fahrenheit, clear autonomic instability, and spontaneous clonus. Which clinical reflex is dictating your diagnosis and management here? Let's walk through this clinical deduction step by step because this is exactly how you have to think on the wards. Step 1. You recognize the life-threatening hyperthermia and autonomic instability. The patient is critical. Step 2 is your major diagnostic pivot. You check the reflexes. The exam reveals spontaneous clonus. That single finding is your answer. It instantly rules out NMS. Because remember, NMS presents with diffuse, stiff lead pipe rigidity and hyporeflexia. The presence of clonus definitively confirms serotonin syndrome. So moving to step 3, you immediately halt all offending serotonergic agents. And for step 4, you push the precise antidote. Because you correctly identified serotonin syndrome, you give cyproheptadine, completely and correctly avoiding dantrolene. And finally, Module 4, High-Yield Pharmacological Traps. We are explicitly cataloging these major cognitive errors so you do not fall for them. First trap, choosing chlorodiazepoxide for alcohol withdrawal in a patient with acute hepatitis. Don't do it. Always pivot to lorazepam, oxazepam, or temazepam when liver function is compromised. Second trap, administering beta blockers to a patient with chest pain from acute cocaine use. We talked about this. It is an absolute contraindication because of the deadly risk of unopposed alpha stimulation. Third, inappropriately checking lithium levels without verifying steady-state timing. If you check too early, you're making dosing decisions on flawed data. And fourth, misinterpreting the hyperreflexive clonus of serotonin syndrome as the standard lead pipe rigidity of NMS. I want to leave you with this final provocative thought to test your newly built diagnostic architecture. If receptor neurochemistry perfectly maps to these clinical toxidromes, how quickly can you now instinctively separate overlapping hyperthermic emergencies based purely on muscle tone? When you truly master these receptor loops and reflex arcs, you aren't just memorizing a textbook picture, you're instinctively understanding the mechanics beneath it.